Okay, hopefully you can see everything correctly. So we're starting with COVID-19. This is obviously a viral infection which reaches your lungs, your alveoli. So your alveoli is going to have a like an inflammatory response to that infection. They're sending like cytokines, and then it's obviously that inflammation over time is going to damage the uh, surface of the alveoli, and we're going to decrease surfactant, which kind of regulates like permeability of those capillaries. So then fluid is going in and out of the cell and the alveoli more than normal. So the lungs are going to flow with fluid, and then because there's nothing to regulate that, the fluid is going to continue to accumulate, and your lymphatic system is unable to filter it out because of that inflammatory response and because of the epithelial damage. So then it's going to leak into the pleural space in between the chest wall and the lungs, and so that's how we're getting our pleural effusion. That was revealed on the CT scan, and that's how we're getting this shortness of breath lasting over a week, which is what brought our patient in. So a chest tube is placed into that pleural space to drain some of the fluid. The tube became kinked and wasn't draining fluid. That's in the chest tube why we weren't seeing any titling, and there was obviously no drainage happening, so there was nothing moving in that tube. So they placed TPA, or tissue plasminogen activator, to like break up a clot, what they thought was a clot, and we're hitting a dead end here because that wasn't the problem. Obviously, it was the kink. So now we're at St. Francis for our second CT scan, and that excess fluid in the pleural space locks the lung in like a compressed position. Obviously, it contracts and expands, but there's so much fluid pushing on it, it locks it down because of like fibrosis. There's like scar tissue forming, and that's how we get what the diagnosis of the trapped lung that was revealed on the CT. Obviously, fluid retention is worsening, and so it's continuing to trap the lung. So perhaps because of like a small puncture in that trapped lung, air is formed, or because of the chest tube, air is forming in the pleural space, separate from the fluid. There's two separate pockets, and so we have a hydropneumothorax, but it's because there's two separate fluid and air. Fluid and air. It's loculated. So now we're heading to interventional radiology to get the old chest tube out and the new chest tube in. But that is not before, obviously, there's going to be a stress response related to like a lack of gas exchange and a lack of breathing, and there's going to be more intrathoracic pressure on the heart, and it is most likely that those two things, specifically in the stress response, sending like epinephrine and that pressure, putting pressure on the lungs and the atria, causes increased atrial workload. It's getting weird signals, and it's fluttering instead of pumping, and the ventricles are filling at an increased rate, and so they're responding with RVR, rapid ventricular rate. And so he has AFib with RVR now. He's getting treated with diltiazem for that. Obviously, with the RVR, we're going to see more fatigue, which it's already fatigued because of the pneumonia. Also, something in his history that is going to make this fluid retention worse is the inappropriate amounts of antidiuretic hormone. When we have increased ADH, we're retaining water because ADH is what recirculates that fluid. He also is hyponatremic, and so we don't have salt to pull the fluid back into the proper space. He also has an albumin deficiency, which I'll say here in a second, but when we don't have the albumin, we don't have protein to pull that fluid back in. And so between those two things, we're really making the fluid retention bad. One thing the patient was concerned about is he had to be NPO for IR, and this is making one of his previous problems before he came in, which was malnutrition, worse because he's not eating. He did have muscle wasting and he was anemic, some vitamin deficiencies, which is likely to put him at risk for that viral infection in the first place. Some more things maybe that I didn't touch on. We're getting prednisone to treat that. It's a steroid to treat that inflammatory response. We're getting a antibacterial, antibiotic augmentin for the original infection of pneumonia. Respiratory therapy is giving him an albuterol, which is a rescue inhaler. They're giving him the nebulizer treatment for that respiratory distress originally, but they're continuing that. And I think that covers everything.